administered slowly, and the client monitored closely. Overcorrection results in serious complications such as metabolic alkalosis, decreased delivery of oxygen to tissues, and circulatory overload. Intravenous bicarbonate, that's NaHCO3, is administered for high
anion gap.
acidosis, and lactated ringers is used when the
Anion
gap is normal. Respiratory acidosis is an acid-base disorder that results in a decreased pH due to excesses in volatile acids. Volatile acids are substances that can be changed from liquid to gaseous states in the body. Carbon dioxide is a major volatile acid in the body. Accumulations of CO2 in the bloodstream will cause the blood pH to drop, and that is the pathophysiologic basis for respiratory acidosis. Respiratory acidosis is characterized by a low pH and an increased pCO2. Let's look at client number 3. Client number 3. pH is 7.25, pCO2 is 55 millimeters of mercury, and HCO3 is 24 milliequivalents per liter. The pH is low, therefore the client has an acidosis. Again, we must now determine whether the origin is metabolic or respiratory. The pCO2 is elevated, so there is increased acid in the bloodstream because of inadequate elimination or overproduction of CO2. There is definitely a respiratory source for the acidemia. The HCO3 is normal, which indicates that there is no metabolic source for the acidemia and that there is no compensation. The client has acute respiratory acidosis. Now let's look at an ABG that reflects compensation. Client number 4. pH is 7.30, pCO2 is 55 millimeters of mercury, and HCO3 is 30 milliequivalents per liter. The goal of compensation is always to move the blood pH closer to normal. As you can see, the kidneys are retaining HCO3 to compensate for the elevated pCO2. The rule of compensation works again. Compensatory changes always follow the direction of the primary change. The primary change was a rise in CO2, and the compensatory change was a rise in HCO3. This client's results would be referred to as partially compensated respiratory acidosis. What are some of the risk factors and etiologies associated with this disorder? When the mechanism is a depressed respiratory center, risk factors include narcotic overdose, CO2 narcosis, and sleep apnea. When the mechanism is abnormal thoracic wall function, risk factors include fractured ribs, Guillain-Barré syndrome, amyotrophic lateral sclerosis or Lou Gehrig's disease, and obesity. When the mechanism is impaired gas exchange, risk factors include COPD, exacerbated chronic bronchitis and asthma, late ARDS or acute respiratory distress syndrome, and upper airway obstruction. The severity of signs and symptoms correlate with the severity of the CO2 retention. The coexistence of hypoxia and respiratory acidosis accounts for some of the physical findings. Most of the others are related to dilation of blood vessels and diminished neurovascular function. The signs and symptoms include headache, blurred vision, depression, lethargy, confusion, coma, psychologic disturbances like hallucinations and paranoia, asterixis, myoclonus, irritability, increased intracranial pressure, vasodilation,
Papilledema,
a swollen optic disc,
cor pulmonale,
polycythemia, chronic COPD, warm flushed skin, and acidic urine. Diagnosis of respiratory acidosis is based on physical findings and ABG results. A pCO2 greater than 45 millimeters of mercury with a low pH indicates respiratory acidosis. Bicarbonate retention and acidic urine indicate renal compensation. Treatment of the underlying cause and the administration of oxygen are priorities. Start oxygen therapy with low concentrations until the hypoxic drive status of the client has been established. Rapid increases in oxygen over the client's normal oxygen level can result in hypoventilation and an exacerbation of respiratory acidosis. Mechanical ventilation might be necessary if the client is not strong enough to withstand treatment of the underlying cause. Metabolic alkalosis is caused by ingestion or infusion of excess base, excessive retention of base, loss of potassium, or excessive losses of acid. The net accumulation of HCO3 results in an increased pH. Metabolic alkalosis is characterized by an increased pH and HCO3. Let's look at client number 5. Client number 5, pH is 7.50, PCO2 is 40 millimeters of mercury, and HCO3 is 35 milliequivalents per liter. The pH of client number 5 is high, which indicates alkalosis. Now we must establish whether the origin is metabolic or respiratory. The PCO2 is normal, which means there is no excess loss of acid through respiratory elimination. The HCO3 is elevated and confirms that the origin of the alkalosis is from metabolic excesses. Since there is no evidence of compensation, this ABG would be interpreted as acute metabolic alkalosis. Let's look at client number 6, specifically looking for evidence of compensation. Client number 6, pH is 7.55, PCO2 is 50 millimeters of mercury, and HCO3 is 35 milliequivalents per liter. Client number 6 demonstrates a compensatory rise in PCO2 in response to the original HCO3 elevation. This ABG would be interpreted as a partially compensated metabolic alkalosis. You'd see hypoventilation in this client. What are some of the risk factors and etiologies associated with this disorder? When the mechanism is loss of acid or bicarbonate retention, risk factors include vomiting, diarrhea, nasogastric suction, hypochloremia, and bicarbonate retention. When the mechanism is hypokalemia, risk factors include hyperaldosteronism or Cushing's syndrome, and thiazide and loop diuretic therapy. When the mechanism is increased ingestion or infusion of alkaline substances, risk factors include NaHCO3 ingestion or infusion, hyperalimentation or TPN, blood transfusion, and lactated ringers infusion. The signs and symptoms of metabolic alkalosis are neurovascular, cardiovascular, and respiratory in origin. Keep in mind that alkalosis will lead to some of these symptoms: confusion, dizziness, muscle tremors, tetany, seizures, hypoventilation, hypotension, and cardiac dysrhythmias. The identification of metabolic alkalosis is based on physical findings, the ABG analysis, and the presence of other selected electrolyte imbalances. The ABG will demonstrate an increased pH and HCO3. The PCO2 may also be elevated if there is respiratory compensation. Hypokalemia would coexist with the ABG findings if it is the etiology of the disturbance. Hypochloremia causes HCO3 retention. Hypocalcemia may develop from increased protein